Welcome, everyone. It's so great to see you all on the line. Thank you so much for joining us today. We're a Redline service led by people with a lived experience of homelessness. We wield world resources to build community, generating the sense of belonging and mutual care essential to securing and retaining housing. We collaborate with artists and cultural institutions to expand access to the art world. We're all about removing those barriers and those high gates. And we still believe that art is more than commodification. And so we avow that art can break the bonds of ingrained social roles and structures and forge new realities in which all can flourish. Sam Banerjee is a member of our founding cohort. He's participated in Redline service programming since 2015. His knowledge base and his intellectual range has brought so much to our community, and we're so happy to be with you today, Sam, as he and all of you as he presents his exhibition in development, an idea that is the exhibition for our time, given the way the pandemic and the rollout of the vaccine has been mishandled. I want to thank every person here today for taking the time to join us. This is a full-day Smart Museum event that centers care. And Sam's proposal does that by addressing healthcare head-on. And you all do that by joining us to hear and to care about Sam and this project. And the Smart Museum does that, providing the channel for all the presenters today. Thank you all so much. Sam, go ahead.
Thank you for the kind introduction. Though it's one of the smallest objects, the syringe proposal here looks at the modern syringe, which has caused so much pain through addiction, and it's seen as a valuable instrument in getting this pandemic over and people returning to their normal lives. The project here will look at the modern health disparities that have risen in this country, from syphilis to insulin to HIV to other infectious diseases, and the current vaccine rollout. The criminalization of drugs, the treatment of drug addicts as social lepers, as well as the community-based groups that have provided healthcare to underserved communities, such as the Black Panthers in the 60s in Chicago, or the young lords in New York City in the Bronx area in the early 1970s. And we hope to bring this exhibition to a variety of documents, some scientific, some artifacts, some contemporary art, historical documents, and a programming schedule that builds a multidisciplinary, multifaceted approach to tackling public health disparities. We also hope to change what it means to be an exhibition by having a part of the exhibition that can be used for safe needle exchange, for vaccination, and other acts of care and healing, which certainly is the theme of this Smart Museum Day today. The exhibition has three broad categories. One is dealing with race and class, the other deals with technology and culture, and the third is, of course, the current vaccine rollout. Race and class have been embedded in this country's structure of medical establishment ever since the founding in memorial. The traditional underserved communities, such as the Native American population, the African American population, and the Puerto Ricans, have been poorly served by underinvestment in their community, lack of access to primary care. And this exhibition will show that these are not the current position, the current state that we're in is a logical sequence of steps taken to get here. It has been a conscious and a deliberate attempt to create a second-class medical establishment for these people. The COVID vaccine has just been a national Rorschach test and it has revealed the cracks behind the system. A particularly good example of where money could have been better spent is the amputation levels that the New England Journal of Medicine documented over a decade ago. Over 70% of the amputations in this country are performed on African American men and women aged 50 and older. Most of these amputations are either due to diabetes or peripheral artery disease. Lack of access to either insulin and other primary care medicine has made these unnecessary amputations possible. The lack of access to proper care, proper rehabilitative care needs to be a part of the safety net that involves all the citizens. We see in certain cases like where we see examples of the Puerto Rican women in the 1950s and 60s who were the first unknowing subjects of the birth control pill developed by Gregory Pincus, not knowing what they had signed up for, and yet a decade later, when the Searle and Searle had patented out, they still did not have access to such medicine. In the Indian Health Service, there was mass sterilization of Indian young women performed by the Federal Indian Health Service, which was, as it is still now, a part of the federal government. There are incidents, as scholars of Jane Sutherland has documented, of two young teenagers going in for a routine tonsillitis treatment and coming out with involuntary sterilization as a result. And these have seeded and created a legitimate climate of mistrust, the lack of faith in medical authority figures, and we are seeing that manifest itself most primarily in the vaccine hesitation in these communities today. And the syringe itself goes back to the Civil War, and it was one of the first treatments developed primarily to give soldiers the morphine treatments in a form that would not cause stomach trouble. Then it became a modern treatment for menstrual pains that upper-class women received. During those initial years, the recipients of these morphine treatments were seen as patients and not addicts. And subsequently, this country, the victim, the recipients of syringe of injections have oscillated between the treatment option that is seen in the case of the Civil War, and the addict option that is seen in the crushed heroin, the morphine, and the methamphetamines. Unlike Western Europe, where there are subsequently safe needle exchange, many of which worked in the 80s and 90s to reduce HIV contact among addicts, there hasn't been a legitimate public service option for addicts to get to able to share safe needle exchange programs. These so-called harm reduction programs in Portugal, in Sweden, in Finland are entirely funded by the government. Sometimes they private agency will facilitate the treatment of such addicts, but it is always done on a government facility, always with close monitoring and a subsequent documentation and a transparency that is needed in such circumstances. And we are still seeing these harm reduction programs effectively treat addicts. And one of the nice consequences, albeit at a lateral angle, is that the public spaces that the former addicts used to use, the public parks, the public fountains, have become public again because citizens in those countries can now freely use it and not have to worry about running into people with medical conditions. And the third point on this presentation deals with the current vaccine rollout. It's instructive to draw perhaps some analogies to the polio vaccine about 65 years ago. Polio, which almost claimed so many victims. And in fact, it claimed 57,000 victims in the year before the vaccine was given out in 1955. President Eisenhower, who was reluctant to expand the role of federal government, did so willingly in this case because he thought that government had an active role to play in making sure that cost was no longer an object for every citizen or every child, documented or undocumented, to have access to that vaccine. And it's well worth noting that the public acceptance of that figures, whether it was Salk and Albert Sabine at that time, was a very different one than that we are seeing given the scrutiny given to, let's say, Dr. Anthony Fauci or Michael Osterholm or any other figures who have become public health figures at this time. Elvis himself, before he went on the Ed Sullivan show in the 1950s, got a shot in front of over 50 cameras from a state of New York nurse, and even talked about it. We certainly need our celebrities and our public figures to step up. And the four presidents making the commercial where President Bush, President Obama, President Carter all have done their part to encourage the vaccine rollout. But there are enormous obstacles that we have seen. We have seen not enough attention being paid to the elderly who are not technologically adept at getting in on these quick vaccination windows, either through their mobile devices or all. Much of the misinformation that has been spread about vaccines in general has not been countered by an aggressive campaign either by the government or nonprofit organizations to do that. So this is also an opportunity to create a robust network of local community groups, recruiting members who are trusted in their own community to spread the value of early health detection, including vaccination, and making sure that there are access to primary care, that the patients have these networks, that know that these networks are available to them, and they feel like they will be treated fairly in these things. And it is the role of the federal government, as well as nonprofit organizations like the Gates Foundation and the Broad Foundation, Broad Institute, to subsidize these worthwhile endeavors. And we hope through the exhibition to have a safe needle exchange program, to have a place where people can get vaccines, and have a place where people can get proper, correct medical information. And I'll let everybody go from there. If anybody has any questions.
I just want to thank Sam so much for that overview of the exhibition. I love the fact that it's a micro history of one single object that then blossoms into all these different themes and tackles such huge, enormous questions. And of course, it centers around an object, which is just so great for a curator such as myself. Thank you so much, Sam. So people can please give their feedback, their questions. You can unmute yourself and talk, or you can feel free to chat them in the chat box. Thank you, Nicole, for your question. Amanda, I see you're unmuting. Did you have a question?
Yeah, I did. I speaking of this like incredible intricate web of just microhistories that you've found and brought to our attention, Sam, I'm wondering visually where the anchor points you might be seeing, right? Like where those microhistories can branch out. Are they, specific iterations of the syringe that might then branch out into, say, the history with the Black Panthers versus the history with more medical stuff? I'm just wondering, like, what kind of anchors can you see as keeping the viewer moving through a track in the exhibit?
Yes, so I mean, let's start at the back first. So one of the things that I wanted to end with was a certain degree of hope. And so one of the things that you've seen in the vaccine is this enormous amount of scientific collaboration. I mean, the Chinese scientist who posted the first genome immediately on the web so other scientists could have access. I was hoping, to be able to get pictures or some type of digital image of scientists and professionals all across the globe working on just for one day, where you would, in one universal time coordinated time, where you go one day where you see people from Australia to China to Malaysia to India to Saudi Arabia to Western Europe to England to the United States to Alaska and Hawaii, just working, and their soul and intent. The objects, I mean, yes, that's one of the ways I wanted to end the project. So that's one of the strands I saw coming out. Another strand that I saw coming out was the active debate, of course, of how monopolies are kind of hurting the average citizen out there. And there was one of the things I never really had time to go in detail about was there's been a retractable syringe developed by an engineer named Robert Shaw, and he has this design in which the vial is completely used. Currently, according to one estimate, we are losing 1 out of 6 doses of the vaccine because we're using a specific design. And he can't get that on the market because the market is all effectively cornered by these large distributors, and there's vaccine unnecessarily going to waste. So yeah, there's the mRNA platform. I would like to maybe show a lot more images on that and how it's going to make fighting infectious disease a lot better too. So it's there are lots of strands in this project.
And
go ahead.
Sam, you also said if you want to talk about the monitor that you would like to have in the exhibition as well.
Yes, so one of the things that I quite couldn't get out, I wasn't really sure how I was going to differentiate between medical misinformation and inaccurate medical information. The scientific process goes through trial and error. And so you are going to have incorrect information and incorrect hypothesis that the experiments will correct. But what I wanted to talk about was the deliberate misinformation that has been published on the web, published on social media. And I wanted to have maybe an electrical monitor somewhere where you would show the false claims and the correct information underneath. And cite the sources. I think that the social media has done good in many cases. I mean, it's been the Arab uprising of 10 years ago would never have really been possible without it, but it's also caused some great harm. It's kind of become the vehicle in which active disinformation is made, and because all human beings have kind of live in their own cubicle these days, we tend to go to pockets that reinforce what pre-existing biases we had before. So that's one object that I was really interested in doing.
Mm-hmm. Thank you so much. Fred has a question.
Go ahead.
Sam, thank you again so much, and I've learned a lot from your presentation. And I'm aware that there's only 5 minutes, so I'm not sure that there's enough time for you to for us to have this discussion, but maybe we can have this discussion offline. So I am a person, except for my mental illness, with extraordinary benefits, privileges, some earned, some unearned. But I do have a severe mental illness. So I just sort of want to make that clear. And I distrust the medical profession, sort of the flip side of what you were saying, not that they're not providing enough services, but that they are providing too many services, that they are churning because the way they make money, the way a doctor makes money, a hospital makes money, is by providing services. So they provide a lot of services that are either not necessary and in some cases particularly harmful. So you talked about 50 years ago. 50 years ago, the way to treat severe mental illness was lobotomy, sticking a spike through your nose. And now we look back and we think that's awful, but it's not clear to me that we won't look back 50 years from now and think that many of the ways people are treated, medical professionals are treating people, will have the same degree of horror. Does this contradict anything that you said, or do you agree?
No, I think there's vaccine hesitancy, for example, in African American and Native American and Puerto Rican populations that come to the same conclusion as many upper middle class white college educated women have. The Jenny McCarthy movement, as I like calling them. I mean, sometimes people come to the same point. I think your experience is very much like the one I've been talking about, insulin and diabetes. The financial incentives until fairly recently were that a hospital could provide the amputation service instead of providing insulin. It was just that way. The incentives were severely distorted. And what you have correctly alluded to is that sometimes it's a profit. In many cases, the profit mechanism becomes the sole or primary goal of a medical establishment. The payment procedure is something that has become an unintended consequence of what I think is a great law, the Medicaid and Medicare law that Lyndon Johnson passed over 55 years ago. But that's an unintended consequence. And you see you see it not only in many of the procedures you talk about, but you see it in the way that the physicians choose their subspecialties. Like, you can't ask a young man or a young woman who is going to end up having $300,000 in medical debt to become a primary care doctor versus or being an orthopedic surgeon, which he or she has the option of paying off their debts and returning to a normal life much more quickly. So yes, it's at the core of it, it's the same issue, the same cause.
Thank you.
I see that
Hey, Rhoda?
sorry, someone was talking. Rochelle, was that you?
No, this is Chris. I had tried to join to the Zoom platform, but it already had started and it just kept saying waiting for the host. So that's why I'm on the phone.
Okay.
Anyways, I wanted to thank Sam for doing this, and I understand some of what he's presenting. And, but I too sometimes do wonder, even though there are some great medical benefits out there, when the science changes so much. Like, I know that you can get, like, if you've had a problem with chickenpox when you're younger and you developed shingles, possibly. Now, when I was growing, most of my life, I remember being something you wanted to be cautious of when you're 60 and up. But then a new drug comes along and tests it on 50 and up, and then you see commercials that just say, oh, 50 and up should get this shot. And I did some research on it, and there's really no science that says absolutely you need to get it at 53. But it's just kind of recommended, and then the recommendations become the new facts. And that's one thing I kind of, in this last year, where you see a lot of stories and a lot of things when it comes to health, sometimes it's just like only some of the information is pertinent, but other parts get left out. I wanted to see how Sam, his thoughts on that.
About over a decade ago, I remember.
Sam, just half a minute, okay?
Okay, so over a decade ago, I saw an op-ed in the New York Times, and it was from a primary care physician. And he says, I can't compete with Dorothy Hamill. And he was referring to the Dorothy Hamill commercial that she made for these prescription drugs. And many of his patients would come and ask for these things, even though it had limited medical benefit in that patient's specific case. And physicians themselves tell me that these commercials make them feel that they're just that it's like as if they're another form of merchandise.
Right.
And so that they feel. And even if the physician refuses to do that, the patient can then go to his or her supervisor or the drug company, which has, in many cases, a lot of power to make that physician's life uncomfortable. So yes, that's a legitimate observation. Any more questions from anybody?
Just wondering, we are experiencing prejudices that come about because of diseases, such as the Chinese pandemic, et cetera, and now we're experiencing other things, and I think that's probably continued on, and other diseases that had come along. A syringe was necessary. Am I correct?
Yes.
So I want to just say thank you to everyone for coming to this call. And Lucia, I know you asked a question, and I think that we answered it when Sam sort of spoke about some of the objects he wants to see in the exhibition. We're hoping to have fine art in the exhibition as well, and perhaps movie clips too. So I want to say that, I want to thank everyone for coming to hear us, to care about us, to care about this proposal. And I want to be quite frank that Redline Service, is new and small, not for profit. We've been operating as an informal art collaborative for 5 years prior to that, with the help of some dedicated funders. the Reva and David Logan Foundation, Weinberg Newton Foundation, Propeller Fund, Awesome Foundation, our generous individual supporters, and some people on the line today who we hope will become partners in the future. Of the many forms care takes, and it takes many forms, today it also looks like us inviting you to join us, to partner with us, to help bring Sam's idea to fruition, with donations to support his curatorial stipend, to providing a venue, to coming forward to loan objects, and to provide your feedback. So details on the different ways to give are on our website at redlineservice.org. I'm going to put that into chat as well. It's a single Redline service. It's not services, just redlineservice.org, one word. And there you'll find our contact details and should you wish, and how to reach us should you have ideas and feedback for us. So I want to thank you all, and particularly thank Sam and thank the Smart Museum for their continued support of Redline Service and our work. They are indeed our Southside hub. Thank you, everyone.
Thank you, everybody.
Congratulations, Sam. It was very good, very informative.
Thank you.